the team with me. I've got Terry Spence, who's one of our nurses, and I've got Sarah Conrad, who's one of our physios. They're wonderful, dynamic team leaders in the group. And I have some of our partners here. I've got a wonderful partner, Jane Schultz, who've been together for 20 years. I like to say partner, not business partner, just so you wonder. And we have Grace. Where's Grace from? One of our nurses hiding in the back. Because I told her if she comes, she might have to say something, so she ran away. I love to see all these men out here. I saw some men earlier. I just want to warn you, there's going to be vaginas, so just be prepared. So, what's that? No, not to give away. So, the transgender clinic hasn't gotten that far yet. So, we're gonna work as a group, so I'm gonna speak for a little while, and then Terry's gonna talk to you a little bit about what she does, and then Sarah's gonna talk to you about what she does. So as yeah, and what you can do, because that's the main part of our focus here. We're not going to talk much about surgery. Jane and I are surgeons, and that's our focus, but we really love that most people can be helped with these problems that we deal with in urogyne without surgery. So that's what we're going to talk to you about today. So that's why the talk is named How to Avoid Surgeons. So what we're going to talk to today about is pelvic organ prolapse. We're going to talk to you about what is it? What the heck is it? And we're not unique to have it. It is present in things like sheep and cows. So I have some farmer patients who've been very great about telling me how they treat that. Just FYI, it's slightly different. Put our patients down. What are the symptoms? How do you recognize if you have it? How can it be prevented, which is a really important thing. And I'd like to see some younger members of the audience, because maybe I think for some of you might be too late. And how can it be treated? Okay, so, and I talked to you a little about that. Then there'll be questions, so please put your questions in here. We prefer more general questions, because sometimes I get things like, well, I've had this surgery and this surgery and this surgery, and can you help me? And I want help now. And then you're welcome to come up and touch whatever you like up here, except the pelvis. Sarah's very protective. Why aren't you holding it now? You're usually holding your pelvis. So Sarah and I have been to Peru a few times together, and she just loves that pelvis. It's always with her. So what is pelvic organ prolapse? Well, most people in the audience have heard of hernias. So it's basically a hernia. And it's a hernia of organs of the pelvic floor that go through the vagina. And what happens is you get a really stretchy vagina, and the organs fall into the vagina and they come out. So things that can fall into the vagina and come out, of course, are the uterus, but also the bladder can come through, and the rectum, and even small bowel. It sounds horrible, but it's not like a hernia where you could actually have a bowel obstruction and be very sick very quickly. It's a much gentler form of a hernia. And I say that only because I did have a patient who got very upset when I told her it was a hernia, because her husband had died of a hernia where the bowel got stuck. So it's not that kind of hernia, but it is a hernia. So I should have, okay, close your eyes, whoever doesn't want to. So this is the operating room. There's a surgical drape over top, and this is the uterus. So the uterus, the cervix is usually way inside the vagina, and you can see that this part of the uterus, which is called the cervix, is hanging right out. So when you ladies get a pap smear, this is the area we take the pap smear from. And up here is the clitoris, and the labia are kind of atrophic. So this is a complete protrusion of the uterus, and it's called uterine prolapse. So this is one of the organs that can come out. But just if you have had your uterus removed, you're still not immune to prolapse, then you can get other types of prolapse too. Symptoms. Usually patients present with complaining something's coming out of their vaginas. So they'll feel a bulge, or they'll notice something down there when they look in the mirror, and younger patients are more likely to look in the mirror than our age groups and older. But it can be scary, and every now and then a patient will show up in emergency because it happens very suddenly and they think there's something growing on them. But it's usually a more gradual process. Because the different organs can fall into this hernia, you can have symptoms related to the organ that falls in. So let's say your bladder's coming down. Because the bladder's hanging outside, it can be difficult for it to empty. So women can complain that they're not able to empty their bladders very well. They feel like they don't empty. Or because they're not emptying, they may get things like bladder infection and run over. They can also have things like incontinence, where they lose urine when they cough or sneeze, or when they get an urge. Or because they're not emptying often, they may feel like they're always going to the bathroom all the time. So those are symptoms of what's called the overactive bladder. And so if you don't have a bulge, but you just have these symptoms, it can be very difficult to sort out what is the problem without going to your healthcare provider. Bowel symptoms, because the rectum can protrude into the vagina, the bowel may not be able to get out very well. And so the cardinal symptom is that people will have to splint to have the bowel movement. So you have women that support their perineum or their actual vagina to try and get the stool coming out. Some of them will say that they're constipated, but it's not really constipation, it's more of a difficulty emptying the bowel. And of course, having pelvic organ prolapse can interfere with your sexual function. Not as much as things like urinary incontinence, but it can be very distressing for women to have a bulge coming out and to feel that they don't look normal down there. What we usually find in male-female relationships, the males aren't usually too bothered by it at all. they just don't care, they'll just go. But women do feel some. So this is uterine prolapse. This is we're going to have you cut you down in the middle, and you can see that your uterus is coming right out. So this is from the side, so your belly button would be up here and your pubic bone here. There's the bladder. So the bladder's coming down a bit too. There's the uterus, and there's the rectum. So this is the picture that you saw earlier with that, I should have warned you about. So when you've had a hysterectomy, you can also have what's called vaginal vault prolapse. So the top of the vagina should still be there, high up where it should be, but with vaginal vault prolapse, you can have the whole vagina turning inside out like a sock. Now these are like extreme pictures, but you can get varying degrees of prolapse where it's very mild. And we talk about it in the old-fashioned halfway system where the bladder's halfway out, where it's just straight at the entrance. That would be like a grade 2 prolapse. So this would be a complete prolapse or a grade 4. So bladder prolapse or a cystocele, as you can see the bladder's hanging out here, and that's why you can get problems with bladder symptoms where you just don't empty very well, because to empty your bladder, you're kind of going against gravity to come out through here. And a rectocele is where the rectum comes down. And if you're trying to have a bowel movement through here, the stool can get easily caught in here. It can be very difficult to pass your stool. So it can be a very troublesome symptom, and women will spend a lot of time in the washroom. There's other ones too where the small bowel can come down as well, but it's not that important unless we're trying to fix it. So this is another picture of uterine prolapse, and you can see what can happen is because it's hanging outside, you can get very raw and irritated, like the skin becomes like skin. And so you see with the uterus here, this is very raw, and you can get bleeding, there's an erosion here. And so when women who've been through the menopause come to us with bleeding after the menopause, we always want to make sure it's not something like cancer, and that's something we're always on the lookout for. So as I said, symptoms of a cystocele or the bladder coming down. This is the front view of the bladder. There's the urethra, where you pee out of. There's the clitoris. There's the vaginal wall that's coming down when you strain. And this is a more mild form. And things like difficulty emptying the bladder, things like incontinence, and things like overactive bladder, where your bladder is always working. You're always needing to go get up at the night, etc. This is a human picture of a rectocele. This lady's also in the operating room because she has a catheter in her bladder. And this is the back wall of the vagina where straining is coming down. She's also got a scar here, which could have been from a previous vaginal delivery or from this surgery. And so what patients do is we'll try and splint to hold their bowel so they can have a bowel movement come. So not life-threatening, but very life-altering symptoms. And this is a woman who's had a hysterectomy, and that's a complete vaginal vault prolapse. We see at least one of these a week as doctors, and they can be very difficult to deal with. So the thing to be aware of is that it's not something to panic about. It can cause very difficult symptoms to live with, but it's not life-threatening. Very occasionally it can be life-threatening because sometimes the kidneys can be involved and you can get kidney function disruption, but that's quite rare. You don't see that very often. And it's not like when I say the bladder or the rectum falls out, it's not like everything comes out of your vagina is exposed. It's covered by the vagina, so it's not, you're not going to get problems that way. And the other main thing to learn is that if you go to a physician for this, and the first thing they offer you is surgery, that's not the physician you should be going to, because there's so many other things that we could do, and surgery complications can sometimes be irreversible, whereas the conservative things that we offer you are completely reversible. Another thing to be aware of is if you go to your doctor and they tell you that you have prolapse, if it isn't bothering you, don't worry about it. Okay? That's when you would start to employ some of the conservative things that my team's going to talk to you about to prevent it from getting worse. But most women that have had vaginal deliveries do have some vaginal stretching and will have some degrees of prolapse. So it's not a disease unless it's actually interfering with your quality of life to a significant extent. And also the symptoms are non-specific. So we'll see a lot of women that are referred for bladder infections, but not all of them have a cystocele. So it's not always, the symptoms may be something else. So it's really important when you see someone about it that you get a thorough history taken and a thorough exam done, because things like incontinence can be for other reasons. And the other thing that I think we're really just becoming aware of is that prolapse can get better, even without us doing anything. So let's say, for example, I remember hearing a story about a woman who had this dog that was really fat because she overfed it. Maybe it was genetic. Anyway, so this dog got arthritis, so she couldn't carry this dog. She had to carry this dog up the stairs all the time, so she was always feeling all this pressure down below. And then when she came to see the doctor, I said she didn't have pressure anymore. She said, "Oh, what did I do? Did I fix you?" She's like, "No, the dog died." So we like to take credit that we've actually fixed things, but sometimes things can get better on their own. Sometimes with the techniques that you're going to learn from my team, and sometimes just from lifestyle circumstances. The other thing is that it's common. And one study done in Oregon showed, which has been substantiated, that there's 11% lifetime risk for women to have surgery for incontinence or prolapse. They weren't separated out, the two. And the other thing is, if you have an operation for prolapse, a lot of the times you're going to end up having another operation for prolapse. And we're thinking this may be because the tissue's different. Women, they get prolapse. And we're finding that there's a genetic tendency. So it's not just whether your female relatives had prolapse, but whether your male relatives and female relatives had hernias. And if you have stretchy joints, and we're just sort of finding out what the genetics are of pelvic organ prolapse. So it's not your fault, you can blame your mother. So risk factors, there's a lot of different studies that have looked at ethnic origin, which is probably the different genetics. Could be lifestyle circumstances too. Certainly the number of births, the more vaginal births you have, the more you have an increased risk of prolapse. And there's parts of vaginal birth that are specifically worrisome that we find with statistics, like if you have a really weak baby, or if you take forever to push the baby out, those kind of things can make a difference. And then a lot of our hard-working women have worked their whole life, and especially, you know, I remember like manual work, so nurses that do do a lot of heavy lifting for patients, or farmers do a lot of the heavy working on the farm, even though they're not being necessarily credited as being farmers, they are. And then things that are part of as you get older, let's say you develop constipation, you're always straining, so you're always pushing on that pelvic floor. Or you're a smoker, you get a chronic cough, you're always pushing on that pelvic floor. Or you gain weight, so there's always increased pressure on that pelvic floor. So all that gravity stuff contributes to what is probably a genetic tendency. So that's that. I was going to tell you an interesting story. All right. What was the other day? I was trying to think of a name. I was with my daughter and her friends, and they're in their 20s, and I was trying to think of a name. If you know that show where they have like videos and they'd like do like to music and like what was that called? And then her friend goes, "It's MTV." He's like, "Don't worry, I speak well." So you don't need to know this stuff, but there's been a whole bunch of research done as to why people have differences in their connective tissue and why do they get prolapse and hernias. And there's a whole bunch of different things looking at molecular structure, and this is just some of them. So if any of you are scientific and know this stuff, that might be something interesting to look at. But it's basically what builds up tissue, what takes it down, and what you start with, etc. And prolapse, you can get complications from prolapse. So I talked about erosion. So this is just a better picture of what can happen. So you can see the skin is kind of getting rubbed, and that's a more severe form of prolapse. So if the bulge isn't completely hanging out, that doesn't usually happen. And then there's another picture of erosions there. So they can be uncomfortable and cause bleeding, which always scares us. It's not really a problem so much as that you want to make sure it's not from something else. The trouble avoiding can be really a problem, especially if you start to get bladder infections, so that can be a real become a medical emergency. And very rarely, because the ureters that come from the kidney, which are tubes that go from the kidney to the bladder, they can be stretched down and fall out with the bladder and then get obstructed, so you can get obstruction of the kidneys with prolapse, but that's also quite rare. But you really should be assessed if you have it for those reasons. So prolapse has been known about for years. They found things in mummies. They found pessaries, which are supportive devices. My nurse will talk about that go in the vagina. They found brass pessaries in the ruins of Pompeii, and they're at the British Museum if you want to go look at them. Really fun. But there's a whole bunch of stuff looking at what people did. So in the 1800s, there's lots of published stuff about things that you may think logically you'd want to do, like lie down all the time. Of course, everyone is going to be able to do that. And because they have these big skirts and like corsets and that, like wear suspenders or something, so you're not always carrying heavy things. So that's that heavy lifting thing we talked about. Avoiding tight clothing. Of course, the corsets are nowadays you have Spanx. Mm-hmm. You know, it'd be a good thing. I think it's stupid anyway, because it's like a sausage, right? Like you wear Spanx, and then it's going to go somewhere. So don't wear them if you have prolapse. Avoiding straining and preventing accumulation of urine and feces. But you got to remember, they didn't have a lot of the physiology back then. And then there were things they put up in the vagina, which we still do today. So, and they said they would restore the tone and strength of vagina. Now we've got charlatans that tell you that laser will do that, which it will not. So that wasn't political, was it, Jane? So the vagina was supposed to be the major support of the uterus, which isn't really accurate, but it kind of is. So what they kind of do is try and coagulate the vagina with different things. They put in the vagina caustic things in the vagina, which we do something similar surgically in some cases, but we don't put corrosive substances in the vagina anymore. Different things were used, like white oak bark and seawater, etc. Things are put in cotton wool to be inserted. there are pictures of people being hung upside down so that the prolapse would reduce.
Yes.
And the best thing that I saw was I had a patient who was cleaning out her grandmother's apartment, and she found this thing, so I took a picture of it.
Oh my God.
And so it was like a girdle, a belt, and this was supposed to go in the vagina, so this was supposed to go up against the uterus, and it'd be held in, this would be the outside of the vagina, and then these strings would support it like a hammock. So it's interesting because her grandmother had prolapse and she had prolapse, so there's a whole genetic thing. And we have a similar thing, which is very much like that for prolapse. So it all goes around in circles. So I'm going to have Terry now come to talk to you about different things that you can do to help prevent prolapse from getting worse and help treat it once you have it. So thank you.
Hi guys. So Cathy's a really tough act to follow. I don't know that I'm half as funny as her, but I'm learning things here with you guys. So I'm one of the nurses, and usually when you get referred to our clinic, you'll be triaged. And I'm one of the few people that you'll probably see first. Often you see the nurses first, and we fight gravity. We teach you a few things. We don't hang you upside down until that prolapse goes back. So that was pretty surprising to learn. And Sarah will talk about some of the stuff with the muscles that you can do, but I'll talk a little bit more about catheter usage, other things that you can do. So, and Cathy did touch on some of these. So diet and exercise, weight loss, that's one of the things. Just if you think about the anatomy, as she's showing you those pictures, your abdomen is right on top of those organs. So if that's heavier, or if you're doing things, you're pushing down, pushing against gravity. So fluid and caffeine intake, that's more towards incontinence. Okay, so there's a lot of things that irritate bladder, and when you're experiencing incontinence, we look at what you're putting in your bladder as kind of one of the first things that we can check. If you come to us with a whole list of the coffee you drink, and the tea you drink, and the pop you drink, that'll be the first lecture you get. We're kind of mean, we take away all the fun stuff, so anything with caffeine or acidic stuff, probably this is a food, like, you know what, I'd like to tell you guys that they gave me about 1 day notice that I was coming to do this. So, yeah, when you come in, so we'll do a full assessment. We'll check what's going on below. We'll ask you specifically what's going on with you. You're not fit with the catheter on your first visit if that's your hopes that you're coming. Usually we're first trying to assess who's the right person to see you and what the right path is. So that is filling out some questionnaires, that is coming in and getting a vaginal assessment and talking to the nurse, okay? So after that, we will do all the teaching. And stopping smoking is another one. Smoking, a lot of the stuff associated with smoking is the coughing. Chronic coughing, just like chronic constipation. Any extra pressure on your pelvic floor contributes to that prolapse as well. Healthy bowel habits. We're trying to prevent the constipation. You know, if you're straining or if you're having hard bowel movements, that's something that contributes to this. She showed you the worst pictures. As I was watching that, I was doing Kegels the whole time. I don't know how to do Kegels, but that's what I was doing. But that rectum can come through the vagina, and especially if you have a history of chronic constipation, that is one of the things we'll often see. So we work on teaching you about high fiber, drinking enough fluids, and what else you can do if that's not cutting it too much. Okay? I'll show you pictures kind of like Cathy did, maybe not those actual pictures, but I'll show you the ones she did inside you. We'll talk about that. She did talk a little bit about some of those risk factors, and I think she got into a little bit more. There is genetics, there is jobs. I find that I do see a lot of nurses, a lot of farmers, and some people who are doing heavy lifting. You know, contributing, like, how many of us are carrying around children until they're 30, 40 pounds? That's also another thing, or moving things. When I say women shouldn't be lifting heavy stuff, it's not really a sexist thing. Our pelvic floor is wide open, they're supported by muscles, and we push down on that. So. Cathy touched on this one. Talking about the bowel habits, squatty potty is kind of addressing just that our bowel has a bit of a turn to come out, and we want
out as easy as possible. So if you do put a little stool in front of your toilet, you're kind of going back to basics where people used to squat to have bowel movement, and that just kind of helps me. Do you have one? Oh, she has the squatty potty unicorn.
What might be fun is, because this is so very not technical, but if you look on the YouTube and type in squatty potty, there's a fantastic 2-minute commercial that explains everything, and it is silly, it has unicorns, but the thing that they do and they demonstrate so well on that video is what the pelvic floor looks like when you're straining to try and evacuate. And I'll just like Terry was talking about, with if you're like if you're in this seated position and your knees, like you can see on the unicorn, are above the hips, this makes a fantastic angle for emptying. But if all of our, and it's unfortunate because I can see why our toilets get so much raised is because of hip replacements, etc. But like that does not help our pelvic floor at all, because now everything is all level. There's no angle anymore. So if you watch this video, you'll see the unicorn gets these the stool placed underneath, and it's like $30 at Walmart. But you could use any stool. At IKEA it has one fantastic one for like $1.99.
Don't tell your instructors this, but if you have a pile of little textbooks.
Yeah. So you put that under, so Terry's my stool, so you put it underneath, and now the unicorn is so happy.
We have some great props around our clinic. We have golden vagina, and we have teddy bear uteruses.
And what I didn't realize is his name is Dookie, but I would recommend that video.
Yeah. So really any stool, but get in that position, and you know when you're visiting some places, there's still some countries where you do squat over the ground to have the bowel movement. It'd be interesting to find out if they have less prolapse. That's a question for the people who do the research. Do they? Yeah. Oh, yeah, and I would think that has a bit to do with it as well. So, smoking, relationship with urinary incontinence is not well understood, but like I said, the chronic cough is one of the things. Any pressure. Treating constipation, we just jump back to constipation. But we already covered that one as well. So the pessary, we did.
I do see this on a lot of people's faces when I first mentioned the pessary or a pulse mouth.
And I move from clinic room to clinic room, and every once in a while there's a great big pessary in the drawer, and I try to hide that, and they always see that one first, so it scares them when I get that one. Okay. We have pessaries in all kinds of shapes, all different sizes. As you can see, we've got little rings, little ones. People say they look like little soothers.
I don't know if we've got cubes. Oh, we do. And we've got even some that look like little cubes now.
Okay, so they look like little dice. But really, everybody's vagina is a little bit different. But you come in when the nurse says that we have a really high-tech way of measuring you. Our fingers. That is what we will decide based on your symptoms, based on your vagina, kind of what's going to be the best fit for you. And sometimes that doesn't always work on the first time. There's some more pictures of the pessaries. I think, is this one in the front an older one? I haven't seen that one yet. Yeah. So there's a lot of pessaries that are more common now, and some that are kind of phasing out, some that are coming, gaining popularity. So, and Cathy had also mentioned that we had many different things. So I just done a history recently in one of the courses, and there was anything from the brass to vinegar soaked sponges. We used ivory and all kinds of things. So medical grade silicone has come a long way. Okay, and these things, many women can use these for years. Okay, so they're pretty inexpensive, easy to try. Like she said, reversible. So you know, if you're going for surgery, it has pros and cons too. It's not so easy to reverse. Okay, you're trying a pessary. If you don't like it, you take it out. I heard someone once say if you wanted to spray it and put it on the Christmas tree, you can do that. So, if you have a pessary in, you actually shouldn't feel it. small, we're quite stretchy, and we don't want it to fall out. So, many women can take care of them themselves. So once you're fit, you can be taught to take it out, wash it up, put it back in. It's quite easy to take care of. And it says here, some people wear it for decades. I haven't covered that yet. Sometimes when patients come in, the only person they do end up seeing is a nurse. So once we go over the conservative management or we try pessary, they might stop there. Some people are just happy with just learning the conservative management. Some people need the pessary and some people go in to have surgery. So it's kind of nice we have the whole multidisciplinary team. So the standard visit when you come in is the history, the pelvic floor exam, not the pessary fitting on the first one, but that usually comes in the first week or two. We like to see how you pee and what you're leaving behind, because often that's not checked regularly. So if you express that you're not emptying well, and maybe you don't even know that you're not emptying well, so we check that. And then we usually see you again in about, well, not always 1 to 2 weeks, but depending on the person and depending on the health of your vagina and what our next steps are, within 3 months you're usually seen again. These statistics are pretty new to me too, but they were quite interesting. It is true that most people it takes about 2 visits to get a pessary fitting and get that correct. Overall success, 71% of people are happy. It's baseless success and happiness with pessary. Just continue having baseless. Gotcha. And then 14% is unable to fit. Not everybody can use a pessary. It just doesn't work for everybody. And that is when we will rely on our lovely doctors to jump in and help us. Here are some pictures of how it fits and how it goes into the vagina. Again, each pessary is designed for something specific, depending on what your prolapse looks like and what your surgeries are. We do have pessary clinics at the lowest hole and at Misericordia, but it is one referral system that you are kind of triaged through. We're hoping to increase places where follow-up is available, hoping that family doctors can do more of this as well. It is kind of specialized right now, but doctors can be trained to take over your pessary care if they're not already. There is a pessary wall. That is all the different sizes and shapes. Is this in this? That's ours. Or maybe change the color. That's lots to choose from. Complications. In 90% of people, there's no complications of using a pessary. 8% there is erosion. She showed you the erosions that can happen even without having a pessary, and if that uterus or prolapse is kind of protruding from the vagina as well, just alters the tissue strength. Vaginal infections, 2%. These are a couple of the pessaries that we use quite often. The incontinence dish, we've got that one here, and then the Schatz. We've got that one here. These are some ring pessaries, and the gal horn.